Morning, Chris Hall, Wake Forest School of Medicine, Infectious Diseases, with a end of January COVID update. What's going on? Well, it's funny how you always know a little bit when something happened more than when it will happen, but it looks like our wave that we predicted here for January peaked roughly 2 weeks ago. So it was, depending on the area and such, but the first 2 weeks of January. Here in the Triad, I think it was a couple weeks after Christmas. So wave wasn't nearly as high as what I thought it was going to be. And that was even with the arrival of the XBB 1.5 variant, which I think is at least 50% of what is circulating now here in the Triad. Interestingly, this wave also peaked up in New York, New Jersey, and New England, where the XBB 1.5 was the predominant variant for the majority of the time, starting from about Thanksgiving. So even though that variant is a bit more transmissible, and it has the aspects of two different COVID viruses that came together, the waves seemed to kind of come and go anyway. So what does all this mean? We'll talk about that here in just a minute. What about all the other respiratory viruses? It is respiratory virus season. There is a common cold virus going around. We call that rhinovirus, rhino meaning nose, the virus of the nose. And that is the most common cold virus that we have. Otherwise, RSV and influenza, the flu, which gave us such a devil of a time last fall, are real quiet right now. And it kind of follows the rule. When COVID comes around, those two viruses seem to go away. And that's what happened. One other virus, though, to pay attention that's going around our community here in the Triad, and that's norovirus. Norovirus is the virus that causes the 24-hour vomiting illness, and that's been going around both for kids and adults, but it's really in the schools right now. So luckily that virus isn't so bad. 24 hours of throwing up, not a lot of fun, but it goes away fairly quickly. And unless you're really at the extremes of age or have other underlying problems, it really is not a major problem. So the XBB 1.5 variant, I think, is teaching us something. First of all, we were a little bit worried that our vaccine might not cover it so well and that it might be more immune evasive. And we just got information that was released yesterday from the CDC, actually, that the fall COVID booster shot, that bivalent shot that came about on the 1st of September, and was directed at the BA.5 variant. That variant is still pretty protective for XBB 1.5, or not, that shot is still pretty protective for XBB 1.5. It seems like it might be more protective than the original COVID vaccine what we were using. So it will give you at least a 50% protection against any symptomatic disease, including the more milder COVID colds. It also gives you protection at a much higher level, probably in the 90% for serious infection, including hospitalizations or death. So that booster that we came about for the fall seems to have helped us. And I think it probably helped us some with the current wave. Would have helped us more if more people would have gotten it. And it's not still too late to get it. There are still people getting COVID. And if you would rather not get sick, that booster will help you not get sick. So I would recommend it. The other thing is that today, the CDC, the FDA Advisory Committee, which will be watched by the CDC, are going to be talking about where to move forward now with COVID vaccination. The proposal from the FDA that the advisory committee is going to hear about is that we transition into one shot for COVID rather than a shot for initial unvaccinated people and another shot for a booster and a different shot for kids. That we'll just have one shot for everybody. And that shot would be given in the fall at the same time we give the flu shot, and it would be changed every year based on the prediction of what COVID variant will be circulating for the respiratory virus season. Problem is trying to figure out what that variant is going to be, because the variants seem to pop up fairly quickly and take control over the other variants fairly quickly. So for instance, BA4 and 5 was what was circulating last summer, and so that's what we decided to put into the fall COVID booster. It was BA4 and 5 specific based on that information. But by the time January came around, BA4 and 5 were down the highway, and we have new variants here, XBB 1.5 now specifically. So the other side of the coin, though, is that the data that we got this week from the CDC says that the BA4 and 5 specific booster still does pretty well against XBB 1.5. So we'll have to see what the committee says. There are two prevailing thoughts, I think. One is that we just vaccinate and don't bother with the fall booster because it seems that just being vaccinated with at least 3 shots keeps you out of trouble, keeps you out of the hospital and from severe disease. And then the other prevailing thought would be let's boost every fall just like we do for the flu. If I was on the committee, I'd probably go with get the flu type shot in the fall, get a COVID shot and get a flu shot, which will help us get through the respiratory virus season. COVID's not going to go away, and so this will, at least for a few years, help reduce the amount of disease, keep more people at work, keep more people at school, keep more people from getting COVID colds, and also help protect people from more severe disease. The one group that we can't forget about, though, are the people over the age of 70 and immunocompromised people. They're still having a big problem with COVID. Even though they may have been vaccinated, this group of people don't respond as well to vaccines, and the vaccine-induced immunity wanes faster. So no matter what we do, we're going to have to figure out a way to keep these people protected from COVID. And that's going to be really important moving forward. And it looks like that group of people would be the ones who we would be really excited about giving an annual fall booster to. And in fact, for immunocompromised people, or people over the age of 65 to 70, it may be that there would be 2 shots. One at the beginning of the season, kind of in August, when we normally start giving the flu shot, and then we would give another one a couple months later to help that population get through the respiratory viral season. But we'll have to see what the committee says today, and we'll talk about it in 2 weeks, and we'll have a briefing then. So what does all this mean? This means that, if you remember, a while back, the questions were always, so COVID's just going to become endemic. What's endemicity look like? How will we know when it's endemic rather than an epidemic? Well, I think we're in an endemic situation now. I think that largely the epidemic or the pandemic is past us, at least here in North America. There are some places, some countries that are still wrestling with it. China is playing catch-up. Their zero COVID policy kept things down for a long time, but when they released it, the number of infections skyrocketed in China, and they're still dealing with the pandemic. But here in North America, I mean, we got through our respiratory viral season wave of COVID pretty well this January. Hospitalizations didn't go anywhere near what they were last year in January. Deaths didn't go up anywhere near what they were last time in January. It seems like this is what endemicity feels like. So COVID's here to stay. The virus will still be around. But for those who've been immunized, particularly those who've been boosted, they'll either avoid the infection entirely or it'll be a minor cold, just like our other colds are. So it kind of looks like the flu, right? We've been dealing with the flu for hundreds of years. And the flu comes around generally in the late fall, early winter. We have a respiratory viral season of flu, and then it goes away. And we get our flu shot in the fall to help protect us and get us through that. So I think that's what COVID's going to look like for us. Now, I don't want to diminish it. Flu's bad enough, right? Particularly for older people or people with other underlying health problems. Flu can be quite serious. In fact, we have, on a normal flu year prior to the pandemic, we would have 15,000 to 20,000 deaths on an average year from the flu here in the United States. So even though I say the pandemic, I think here in North America is behind us, and we've entered a period of endemicity, there will still be people who get it, and there'll still be deaths, and vaccination will still be one way, and probably the best way yet to protect our vulnerable populations. So with that, I think I'll go ahead and take questions.
We had a question about Novavax.
Novavax,
the
yes.
new release that came out that it might be better at producing antibodies and protecting you from COVID versus the mRNA vaccines that we've had.
Yeah, so Novavax is the adjuvant recombinant produced protein vaccine. So it's different. It's not a messenger RNA component. It's actually giving a protein, which is how we do for Hep B and for HPV and a lot of other vaccines. We do it that way. So that is available. That is available only directed at the original COVID that went around, pre-Omicron, pre-BA4 and 5. So we don't know exactly how well that vaccine's working against XBB 1.5. That data's not out yet. And so we'll have to wait and see if that data comes around. That vaccine's a little bit harder to find, but pre-BA4 and 5, pre-Omicron, it seemed like it did just as well as the messenger RNA vaccines. But we don't really know now with the current variants. I would think that because that vaccine's a little bit harder to make, that we'll have to see whether it also comes up with a variant-specific vaccine. The other thing I should mention, by the way, when I was talking about the pandemic largely being behind us now in North America and then entering into a period of endemicity, this is a bit of a caution, is that it's going to depend a little bit on whether or not we get a big new, completely different looking variant that comes down the road for us. So far, since last January, most of the variants that we've had popped up are still largely within the Omicron family, or look a lot like Omicron. So we've had small shifts, but we haven't had big changes. Now, if one came down the pike that was totally different, so that our immunity that we've had pre-existing from either being infected or from having had vaccine doesn't cover it, then we could see another epidemic or pandemic. And again, this looks like the flu. If you remember, 2009, we had an H1N1. That was a huge change in the flu strain and that flu virus. And we called that the swine flu. And then and that was a big epidemic. And so we have those every now and then with the flu, roughly every 15 years or so, 20 years. We tend to name them, if you remember, if you're my age, the Hong Kong flu, which is back in the 60s, and then of course the Spanish flu, 1918 and 19. So even though the Spanish flu wasn't a new virus per se, it was still the flu, but it had changed enough so it caused havoc and a pandemic across the world. So that's just the reality of viruses. And COVID is going to be along that way too. So back to questions.
So if COVID is endemic, kind of off of that, will the CDC update isolation guidelines? At what point will we not need to isolate after
Yeah.
COVID?
Will the CDC update their isolation guidelines? I hope so. We'll have to see once we get a few weeks past this wave and get out of the big problem in China right now. The thing with having so many cases in China right now is it gives COVID maybe more of a chance to throw a new variant out there. So I think once all that settles down some, yes, CDC will be talking about that. We don't really isolate people with the flu. We don't really isolate people with colds. So if COVID's endemic, would we continue to isolate? I'm guessing that what will happen is that we'll have a lot stronger message on what to do when you're infected with any of these viruses. While COVID still has an isolation dictum, I mean, it's a public health policy. The other viruses don't, but still, do we really want to be spreading around the flu? Do we really want to be spreading around all these other respiratory viruses, RSV, so on and so forth? And the answer is no. So, as a society, I think we'll just have to be more cognizant of when we're sick with these viruses, is to being a good citizen and keep from spreading it. So, for instance, the flu, most people, of the amount of virus they shed is considerably diminished 24 hours after the fever resolves. Even though you can wear a mask during the worst 2 weeks, and that'll help you not get it. So I would say yes, I think they probably will eventually revise that.
Another question we have is, if you got the fall bivalent booster in September, should you get another booster now?
So if you got the fall bivalent booster, and that would mean after 1 September, because that's when we started giving it, then you don't need another one now. There may be a recommendation for immunocompromised people to get another one here this spring. We'll have to see. But technically right now, if you got the fall booster, it looks like it's still hanging in there for you. That study this week from the CDC also, it was basically 3 months of information. So we know for at least 3 months after that booster that it's hanging in there with pretty good overall protection rate.
And one more question we have here is, hearing that some doctors are not prescribing Paxlovid for healthy over 65 COVID patients because of the rebound effect?
Yeah, so the rebound, so what is rebound? COVID rebound, we became mostly aware of it when we started using Paxlovid, the antiviral for COVID. And what that is that you take your Paxlovid for 5 days, you start feeling better. Most people start feeling a lot better, and then a couple, 3 days later, it comes back, mostly stuffy nose and sore throat. It doesn't come back usually as severe, but you still need to isolate when it comes back. So There's nothing magic about Paxlovid really causing the rebound. Maybe it just makes it more obvious because people who don't take Paxlovid can rebound too, even though they didn't get antiviral treatment. And personally, if somebody's over the age of 65, or if they have underlying health problems, I prescribe Paxlovid to these people because if you look at our hospitalizations over the last 6 months, the people who are getting in trouble are people over the age of 65 to 70. And Paxlovid does keep you out of the hospital. 85% protection for keeping you out of the hospital if you take Paxlovid. So I don't think trying to avoid the rebound it makes it worthwhile to withhold Paxlovid for the older group of people. Now, if you're 30 years old, I'm not so sure how important it is for you to get treated, unless you have other health problems.
I got a couple of questions here. You talk about they're debating on whether to make it a single shot for everything. Now, the regular flu is a different type of I guess, pathway other than the messenger RNA or whatever. Can you combine them, or will they be put them both on
Yeah.
RNA, or how will that?
Yeah. The question is if we're getting a COVID booster and a flu booster at the same time of the year, why not combine them into one shot? And yeah, there's a study going on right now. That's been done. I think that's Moderna did that. I may be wrong, but that is out there and being studied right now. So
so the flu shot is still its type, and then
yeah, right now the COVID shot and the flu shot would be separate. You can get them at the same time, one in each arm.
but nothing will change about either one of them.
Nothing will
About the type of shot.
Right, nothing will change about either one of them. So, I mean, every year what we do is sometime in spring, we decide what's going to be in our flu shot. We take 4 different strains of flu and put them together in one shot, and then that's what we give the next season. And it's the same shot for everybody, and the age range is different. It's still the same shot. So the goal here is to simplify it some. Right now there's so many different shots out there, depending on your age and whether or not you've had it before. So I really applaud that decision. It should be simplified.
With them being combined, and I know there's still people out here, there's still some people that are just dead set about the COVID shot and the type of virus and everything. Will they still be able to get a flu shot separate from the cold shot? Or are they just going to go to that one shot?
Right.
Take
So
either way you want
right.
it, you're going to have to get both.
So for the people who don't want the COVID shot, yes, you could still get a flu shot. That would be separate. It won't be one combined shot. We'll still have a separate shot.
But they'll still offer it.
Offering, yeah. They, a lot of the people who have not gotten vaccinated with COVID have had COVID by now. So in a way they have been vaccinated, kind of the hard way, I guess. But not everybody. There are still some people who've never been vaccinated and still haven't got COVID. Eventually you will get it, but because it's not going away.
One other question, now that you're saying we're kind of coming down off of the endemic, you say then the pandemic, there's still talk about it about people still, making mandatory masks and stuff like that. Like, isn't the government still trying to keep it mandatory on planes and stuff like that? Or is that?
So mandatory masking, largely the only place where masking is still mandatory is in acute care and outpatient health facilities. and that's OSHA. That's that's the Occupational Safety and Health Administration, and so that's not like the otherwise where we had mask mandates. I don't really think we'll be seeing mask mandates come around again in the community unless we really get thrown a nasty different variant and things went back like they were 2-3 years ago.
I'd heard something about that they're still considering it on airplanes, bringing it back to airplanes. Is that anything there?
I don't think we're going to end up seeing it back on airplanes. I think if you want to get on an airplane and you're in the middle of respiratory viral season, if you don't want to get sick, you can wear a mask and you can protect yourself. So I don't think we're going to see it back on transportation unless we really get thrown something new and different. But that's it. All right. We'll talk again in 2 weeks. We'll have more information about the recommendations for how fall boosters will go for COVID, and we can talk about that then.